Good afternoon. Welcome to the third in our series of trainings, creating trust-based, patient-centered, anti-racist patient-provider relationships. This is a four-part series presented this time by Leslie Gregory, who will be speaking on social determinants of health and health disparities. We're currently waiting for her to get back to her home location because she was seeing a patient. She's a working PA. So we want to also thank our training sponsors, Trillium, Pacific Source, the Oregon Academy of Family Physicians, and additional sponsors, the AARP of Oregon, CareWorks of Lane County, HIV Alliance, Oregon Medical Group, strong integrated behavioral health, and the Oregon Health Authority. What's been interesting in terms of this experience, was started out of NAACP, Lane County branch of a health committee that wanted to be able to begin and sustain a conversation around health disparities. I presented the lead workshop, and as an addictions mental health provider, I've long been involved with trying to improve various healthcare systems generically and also for people of color. So I think we're in for a treat. My team members inform me that our presenter today will have a, shall we say, stimulating outlook and a productive one. In the conversations that I've also had with the medical community that tends to be often relying on evidence-based material, some of that material has only recently been focusing on race and racism, even though the conversation among practitioners of color. So for example, I'm part of a lineage in Black psychology that has basically started to define racism as a disease 70 years ago. So despite that acceptance within credible sources, that had yet to be made part of the mainstream approach. Even the conversation on critical race theory, which is largely a collegiate discussion, not a K through 12 discussion, is meeting certain resistance, even though it attempts to humanize large parts of the population.
Hello, can you hear me?
Yes.
Okay, I am so sorry to be late. I cannot apologize enough. I am just absolutely appalled at the multiple failures that have caused me to be late today. I just really want to apologize to everyone.
No worries. Glad you're here.
No worries.
Yeah,
You got
we're ready and we're patient.
Well, so I have to say, one of the reasons that I didn't initially upload my PowerPoint presentation was because I knew I would be working on it until the very last minute, which I wanted you to know that literally moments ago, I got another email that is causing me to update things. So I just, first of all, everybody knows who I am, right? Is there any kind of introduction that people would need that would help them to identify or understand my background about why this is such an issue for me?
It'd be great to hear a little bit of an introduction.
You could go into it.
Okay, so I practice primary care medicine here in Selwood, which has been called quote, the whitest of the whitest city in the nation. And so that's kind of where I have been professionally living for the last 20 years. Okay, so I became a PA in 2000. I worked very briefly in Vancouver, which could be arguably even whiter than Selwood. But anyway, and so I've been practicing there under the sort of mentorship of a preventive cardiologist who started the practice. And so preventive cardiology is kind of where I live. And I believe in it primarily because, number one, if you prevent heart disease, you prevent just about everything else. You reduce your risk, at least, for other things like cancer, diabetes, et cetera. The other issue is that as a Black American, it's my particular risk factor. And I lost my father to heart disease at a very early age of 61. So that's another reason that it's sort of close to me. The other reason is that my mother and myself are both American Heart Association Go Red for Women ambassadors. And the protocol that I have adapted from her protocol, specifically targeting racism, was adapted from her protocol that she initially started because she was doing screenings and work in the area of sickle cell anemia, which, as you may know, is a particularly African-American centered and very painful chronic disease. So that's how I was mentored into medicine, was by helping her with the mobile unit that she developed in Ohio to basically recruit in and test for sickle cell in the entire Northwest Ohio region, which she accomplished. And after that was done, then she moved into screening for heart disease, another particularly devastating chronic disease in the African-American population. So that's how I got mentored into medicine. And that was basically in my junior high school and high school careers. And it kind of piqued my interest in medicine. And that's what drove me into the work. Also, my father was a firefighter medic, and I wanted to follow in his steps initially, but they weren't hiring Black women, well, women at all. But because he had sued the division for racist practices, even once I was able to apply, I had people from the fire division show up in my house, actually, in my driveway one day, and I'll never forget this, when they said, you've done well on your qualifying, you've done well on the physical agilities, the application of the background investigation and the academic qualifications, but with that last name, you're never going to make it out of a building alive. You need to find another profession. And so I did. So that is sort of a little bit of background about the fact that both of my parents were civil rights workers, not because they chose, but because of their lives, just the trajectory of their lives. And so I am a middle kid, one of four. And I also lost my oldest brother to drowning when I was 15 and he was 20. And the fire division at that time did not have a water rescue division. And my father, who was on the fire division, developed that afterwards, having found that there was nothing. And so that is another part of what I really wanted to go into today, which is a conversation about racism as trauma. Because I think that our entire nation in this moment is suffering from a sort of national trauma around the several aspects that brought racism into the awareness as a public health crisis. So I think that's a good place to sort of jump into what I wanted to discuss today, which is the various levels of trauma associated with racism. And I think one of the reasons it's been so very difficult for our nation to understand that racism is a public health crisis is because of the narrative that racism affects only Black people, as if only, in quotes, is an appropriate adjective, no, or adverb, I cannot remember. It is not. However, until the narrative around public health begins to affect those of dominant culture, it's very difficult to get anything recognized, right? Unless it affects dominant culture, it's not going to be perceived as a public health crisis. What has finally driven that narrative, ironically, is this virus. And so finally, because Rochelle Walensky, head of CDC, and she's fairly new, began to realize that it disproportionately affects people of color, She is now has just recently announced, and I don't know if everyone's aware of this, but she only recently announced racism as a public health crisis. Now, I believe that happened perhaps in April. Time's been flying ever since she did, because this has been a huge push for my campaign and my nonprofit for the over 10 years. So that's the other part of the story. So if you're ready for this, in 2015, I wrote a letter to CDC. The head of CDC at that time was Tom Frieden. And I asked him to declare racism a public health crisis so that we could begin to mobilize the same protocols that you're seeing for public health crises under any circumstance. And as you can see, what they're doing with the virus is identifying those most vulnerable, right? They're going after the people on the front lines and those most vulnerable, those with the comorbid conditions, the aged, people in crowded living situations, etc. We're also trying to do prevention, right? So we launched this hugely costly campaign to look for vaccines, right? We've also done a huge education campaign about covering, washing, other sort of blanket preventive measures. And then once we've gotten the vaccine, we're disseminating it. And so the big push is to get everyone vaccinated, et cetera. So these are some of the interventions we can think about to use once we've actually identified racism as a public health crisis. The problem is, and again, I think this is the piece that is so important about one type of racism that I really want to dial in on, which is institutional racism, okay? This is the one place that we're seeing institutional racism persist, in that the new data that just came out, again, from the Bureau of Vital Statistics, has now shown we're failing. African-American males have now gone from 5 years deficit against white males to 10 years less life expectancy compared to white males. 10 years. And this is new. Like I said, this has just come out in the last month. And a lot of people are chalking it up to the virus. However, and again, I cannot stress enough, the real foundation of this deficit is institutional racism. Why? Okay, so important pieces to pull apart here. Number one, we know people of color have a less likelihood of going for the vaccine, though it may be available. And again, we need to change that narrative around the health deficits associated with lack of access. Yes, there is some lack of access, but that is not the primary driver. Despite access, we have a huge mistrust of the medical system. And so a large percentage of people of color, and not people of color too, we have a lot of people in the country at large who just have a great mistrust of the medical system in general. And so we have a huge pushback on anti-vaccine. Now, the ironic thing about this is the phenomenon called strange bedfellows, because we also have a lot of white supremacists who are vaccine deniers as well, following the words of our previous administrator. So we find some very bizarre phenomena associated with institutional racism, and it goes on and on and on. And we can get into that at another time, certainly if anyone has questions in that regard. So what we're seeing is a great deal that we can learn from the virus in terms of fighting institutional racism, but we also see that the virus has flared up the symptoms of institutional racism. And again, these are some of the very bizarre sort of parallels that we observe. When we observe these bizarre sort of parallels, what we see is an increase in mental health problems around not just the virus, because that's another public health crisis, but also around racism. Why? Well, because when the primary care system of our entire nation, which is CDC, finally comes out and recognizes that racism is a public health crisis, it causes people who did not even believe it existed to now have a great deal of stress around something called cognitive dissonance. And so what we're seeing is a great deal of majority culture saying, well, wait, institutional racism was just a word. It was just a concept. It was just an excuse for people of color to do poorly. Now having a prominent white clinician in a position of power and authority finally validating something that, you know, a substantial part of our population has been trying to say for a very long time and being marginalized around it, being poo-pooed about it. Now what are we going to do? How can we, you know, how can we believe this when all this time, and particularly for the preceding 4 years of a presidential administration poo-pooing it? Now what do we do? How are we to believe this? How are we to digest this? And so we're seeing a lot of stress and cognitive dissonance in majority population. I think I did see a question about how can we convince our patients to get the vaccine. I think one of the ways we can do that, and another reason why my protocol is so appropriate for this moment and for these issues, is that it presents a perfect opportunity to go into these marginalized communities with clinicians of color who've gotten the vaccine and can provide examples. And this is what we need. And so my protocol to actually fix it, which is the other reason I really wanted to spend a little time on that today, because I think the other problem we're seeing is when people call out these public health crises and people are finally getting acknowledged around the fact that their symptoms are validated, they are seen and heard in a environment, a medical environment that has largely ignored them. When we're finally being seen and heard for this issue and then said, oh, there's nothing we can do about it, okay, that again is trauma. Because in other words, we're saying, oh yeah, we finally figured out that this virus, for instance, is a public health crisis, but we're not going to give you the vaccine. Imagine how that would feel if after decades you've been crying in the wilderness saying, hey, this is a public health crisis, racism is hurting me. And then finally, after decades, you heard someone finally say, oh, yes, I see that it is hurting you. But then at that moment say, okay, but we have nothing to do for you. We're not going to do anything about it. Okay, that is compounded trauma. And so there are various forms of trauma that are associated with racism. And I really would like to talk about them. But I do want you to also hear me when I say the way to, as a healthcare provider, encourage patients of color and validate the mistrust, but actually to get the vaccine, you actually can do both. And that is a very delicate conversation to have, and one that is most effectively had by a clinician of color, which, you know, as you probably know, is a real shortage in this area. As a matter of fact, for many years, and I don't know if it's changed now, but for many years, I was the only Black primary care provider that we could find in the state. And when I actually called the Oregon Medical Board, because I was looking for a primary care provider for myself, they told me, oh, we don't know, we don't track that. And I was like, are you kidding me? I fill out your paperwork. I know you track it because I have to write my ethnicity down for my licensure. And yet they tried to deny tracking it when I asked for my own. So you can see this is another example of institutional racism. And to be frankly and explicitly lied to by the medical board to which I pay dues in that moment was just, you know, I was more than offended. I'm sure you can imagine how it would feel if it were yourself. So these are the kinds of institutional layers that particularly abuse people of color. But, you know, even it wouldn't matter my ethnicity if someone lied to me from my own medical board about anything. It would still, you know, and you can see now how people of color do have a mistrust in general of the institutions that are tasked with our primary care. So I think that that would be one way that I would answer your question. Is it Haley who asked the question about how to address that? I think one of the ways I would do it is certainly to validate their concerns. And I think that's super important. Good to meet you, Lauren. I can't see you on the Zoom, but that's okay. Don't worry about it because I'm actually despising Zoom in the moment. It's been going on for over a year now and I'm a little crazy over it. But I think one of the ways you can do it is to certainly say, yes, you're correct. the marginalization of Black bodies, the exploitation of Black culture, the fascination with Black excellence. All of these things are a bizarre way of painting this picture of sort of, it's almost like when you were a little kid and you poked at a strange bug or something, you like pulled off the wings and you kind of, because it's a fascination, it's a fear, and it's an envy, all at the same time as we see these bizarre emotions playing out in a cultural way with regard to and around Black bodies and Black life. And so it is damaging, just like you can kill that little creature that you're fascinated with just by poking at it. So it is dangerous, but also it is traumatizing. And I think that's the piece that I really want to sort of clearly elucidate more today, because I think the trauma of racism is something that we as a nation need to start dealing with, or we're never going to really address the public health crisis that has just been recognized. And so I think we need to look at a couple of different things around trauma. Number one, there's acute trauma, the kind of things that most people identify when they talk about trauma, right? A car accident, a shooting, a violent act, or even a witnessing. This would be an acute form of trauma. Then there's the chronic trauma, the little bit of every day, walking in the door and being triggered around the fact that at some point you came home and someone was invading your home. So now every time you go into your door and unlock your door, you're going to have that same triggering. That's an example of chronic trauma. I think another type of trauma that we're really dealing with in these days of the virus and racism and the protests and the climate change and the, all of this is the danger of unrecognized trauma. Very often it is chronic. It can be acute. And I've actually had a great deal of those described to me of late in my primary care setting when women talk about, when I ask them if they've ever been a victim of trauma, and they give me this confused look like, I'm not really sure. He groped me and he wouldn't stop when I said no. And I'm like, hello. And so they don't recognize this as trauma. Why? Because it's almost a common narrative among women. And so I think the unrecognized aspect of trauma is also very, very dangerous because it does live in the body. And so as people of color, we often don't recognize that chronic trauma that makes you feel like there's a cop in your rearview mirror all the time, but it's not necessarily associated with an issue. Okay, and that's one of the hallmarks of unrecognized and chronic trauma, is that it is often not one issue. And so I think these are very important. And yes, Fatima, these are all things that are related to most people of color. So it is not exclusive of the Latinx community. And so very often it will be the same sort of thing, only if you have, and let me back up one more minute because it will help to elucidate this a bit more. Another type of trauma is transmitted trauma or intergenerational trauma or epigenetic trauma. These are the types of trauma that can be transmitted in the body, literally has changed the DNA, literally has been something that you can transmit from your parents. And I think that is another way that people of color can be victims of chronic and or unrecognized trauma. And this is something that, for instance, the Asian community may be able to understand in terms of the internment of the Japanese Americans, the immigration issues around Latino Americans, the kidnap and rape and sale of Black bodies that can be transmitted in people of color. So it's just super important that everybody understand the layers of trauma that can be associated with the mistrust of these larger systems, and a way that a person who is not a person of color can help to validate and say, epigenetically, you can have trauma. And no, I cannot necessarily empathize to the extent that it has happened to me as well. But because it is well documented, because it is an aspect of your care in my clinic, and that's a way to be a trauma-informed and racially and culturally appropriate clinician, is to say, no, I'm not a person of color. No, it would be hubris of me to assume that I can identify, but I can at least validate for you that this has been, might be, and could continually be an aspect of our need to care for you today. And so that's a way that you can validate any of your patients of color. And if you're not a clinician, a client of color, or a, whether, no matter what encounter you're having, even if you are a checkout person in line, as a cashier, if you see people in your line kind of cutting in front of each other or not seeing people of color. I mean, I've actually remember once, long time ago, I was working at a Burger King, one of my first jobs. And I remember it was just around the corner from my home. But I remember how sometimes it would be, people would come in and they'd be looking at the menu over the top of over the head of the people behind the counter. They'd be looking to try and make their choice and moving into, having made their choice, moving in, and then just have other people just cut them completely off as if they weren't seen at all. And I remember at the time, and, again, I was very young, but I would remember saying, excuse me, that person right beside you was like actually here before you. And, and then of course there's this whole sort of overreacting of how, oh, I'm so sorry, I didn't see, and it's like, okay, don't take up so much space with your apology, just move out of the way and let them get there. You know what I mean? And so it's this whole sort of taking up space of dominant culture, whether it's as a victim, as a perpetrator, as an observation, maybe just observing, but it's, oh my God, I was so upset when I saw this happen to somebody else. Really? You're going to take up space about having witnessed. How about you give the space to the person who actually was the victim? I mean, sometimes the behavior can be just bizarre. And so I really want to bring up these various issues so that those of us on the front line who are actually exposed and exposing others to our issues with racism in a general and interactional way can be more sensitive. And this is the opportunity for you to ask those questions that you're not going to be able to ask out in the world. And so I am putting myself in a position for you right now to say those questions that are going to be difficult, uncomfortable, I'm not going to ask them because I'm going to look like an idiot. Now's the time for you to ask those questions, because I'm telling you right now, it won't be appropriate under other circumstances, because so many people of color are being asked to do this emotional labor without compensation. And I think it's important for you not to do that. I think you're going to feel better, about yourself. We all feel better about ourselves when we don't do that. So the question from Zach is, how would you encourage a patient to open up about it all if you feel some of this energy is on deck while an office visit? So I think that is a really legitimate and excellent question. And I think the first way you want to approach something like that is to ask permission. Okay, you're going to ask permission to say, hey, do you feel comfortable enough? Would you feel comfortable enough, or would it be helpful? Those are some of the ways that you can even begin to sort of preface a question, because there are times when a person of color or a woman or a gender or non-binary person might come into your presence and be for care and just not have the bandwidth to go into it in that moment. I mean, there have been times when I can tell, a patient comes in, they're running a little late, they've got some emotional stuff going on, and it's their primary care visit, for instance. And I'm going to go through their review of systems and check in. How are you doing? Head to toe, mental health, la, la, la. And I'm saying, how are you doing? Did you sleep well last night? And if that person tells me, no, I didn't sleep well last night, matter of fact, I'm feeling kind of stressed out, had too much coffee this morning, was late coming in here, terrible commute, blah, blah, blah. I'm going to say, look, maybe this isn't a good time to go into your mental health. How about we just talk about those issues, chronic issues where, that have always been your issue. We're not going to go into it, and we'll follow up on some emotional stuff later. Or, how would it feel for you in the moment to get some of that out right now, aware that we need to do some of those primary care preventive, buttons we have to click anyway. So those are some of the ways I try to approach it. Is this a good time? Do you feel like we can cover that today? Would you like to come back on another day and deal with that stuff while we deal with the bare bones kind of stuff today? Now, if the patient came in and there's a biometric issue that could be affected by it, so Again, for instance, I practice primary care and primary preventive cardiology. So if I have a patient who comes in and their blood pressure's up, I'm going to ask them about it, period. It's, you know, it's a part of the issue. I've got to ask about it. So, you know, I'm noticing your blood pressure's up a little bit today. Is there anything we can think about that might be affecting that? And then I'm going to go through that list. And of course, the emotional aspect is going to be in there. So I think it's important that you, first of all, you have to contextualize all of these questions. And there's actually, if you'd like to take a look at it, you can Google it, contextual psychology. And I think that's an important, another aspect of what we need to be talking about when we look at the disco ball of racism, which is exactly how I refer to it. I refer to racism as a disco ball. I think it's important because a disco ball is omnifaceted. So if you can remember those old disco balls back in the day where they circulate up at the top of a dance floor, and they're all these little different facets, and depending on which facet you put the light on, you're going to get this sort of spinning lights around the room. I think that that is the way racism should be. Is an issue, and having it denied all these years. Oh, racism isn't an issue. Look at Obama was elected. Oh, racism isn't an issue. We passed the Civil Rights Act back in, you know, whatever, and finally took till Juneteenth to actually put it into place. And then even after that, we're continuing to see the devastation of successful Black towns, which is only again being actually researched and brought to the fore. So we are just now learning about the layers and ways in which racism has persisted throughout our culture, and it is only now being validated and recognized. And so, again, this is going to be another type of trauma. All this time, you know, people of color have been going, hey, 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 and having it denied, such that they've had to find other outlets, other means, other ways of coping with this trauma, with the inequities, with the job loss and the economic handicaps and all these things. And now, having found all these other ways of dealing with it, finally someone's going to come out and say, okay, yeah, I guess racism is a thing. And now what? Nothing to do about it. Can you imagine? You know, I would just wonder if those of you in dominant culture could just try to imagine what all that might be like. And if it's a hard thing, then try to use an analogy in your own life. We almost all have something with which we can identify, whether it's just, you know, a lisp, or, you know, some sort of, you know, needing glasses, or being overweight, or having a chronic pain issue, or any sort of complaint, mental or physical complaint that is in your life, that at some point you tried to explain to someone and they said, oh, no, that's not a thing. And then finally getting some attention around it, and then saying, well, you know, okay, so I admit you do have a visual impairment, or you do have crappy teeth, or you do have whatever, but we're not going to do anything about it. And just to imagine how that might feel for you. Now, Mark, I think that's a very important question about how one might want to address racism in the moment. I think the important issue is to look at it very individually. And that's the kind of thing that we really need to be careful of, because it's going to be a completely different thing to try to address racism of someone cutting you off as you're making your way to your seat on a bus, versus, you know, someone refusing to give you a job, or a home, or an apartment to rent, etc. So I think the instances are very, very specific and need to be addressed in a very specific way. Why? For the exact reason what we've been talking about. It impacts your health. And so just like we might want to be very careful and ask permission of a patient who comes into our clinic in the moment, we also need to ask of ourselves, do I have the bandwidth? Do I have the strength today? Is this a good day for me to try to address this issue? Because, you know, there will be times when, you know, quite frankly, it's a matter of personal and global self-care, that you are aware of your own bandwidth in that moment. And I think that's another thing that racism has kind of done to those of us under the gun, is to never have that awareness. You know, it's like, you know, get up every morning, push, till you get the job done, go home, get to work, what you got to do, you know, come home, take care of business, kids, shopping, whatever you have to, housework, blah, 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 pass out in bed at night and get up the next day and do it all again. And very often this does not lend itself to the kind of self-awareness that is even appropriate to ask that question of yourself. So it's super, super important about learning the self-awareness to even be able to ask yourself that question and get an appropriate answer. Yes, we did see that House Bill 2936, law enforcement officers, that was, I think that's local, isn't that Oregon House Bill? Yeah, so another really important point, and this is a great opportunity for you to see sort of the nightmare that has been working in this field for quite a while. So for the last year and a half, we worked on House Bill 2337. It was with a very diverse group of people. We had, you know, the Latino community, we had the tribes, we had American Public Health, or Oregon Public Health Association members, myself in primary care. We had, you know, a great diverse group of people working on House Bill 2337 to declare racism a public health crisis and to implement my protocol to address it. And even though we had billions in the relief funding to use to implement the changes we recommended, and we had a very tight budget, we put it together, we had, you know, it was vetted very well. We had accountants taking a look at it. We had, you know, it was a very elaborate process. And we put together a very good bill. It was backed by many of the members. We had, you know, Bynum, Mirren, couple of other really, you know, we had a lot of backing for this bill. We pushed it, and it was right after 2937. And the bill was successful only in that it was adopted, that yes, we would declare racism a public health crisis, but no, there would be absolutely no funding to do anything about it. And you look it up. Look it up. HB 2337. So my point is, and again, this is exactly the kind of atmosphere we're living with here in Oregon, where, you know, we're just finally starting to get a clue about the fact that racism is an issue, but by God, we're not going to do a damn thing to fix it. And again, I think that that is a real, you know, it's a problem, and it's another danger when we push a psychophysical health issue into the political arena. People die, and that's exactly what we're seeing.
Hey, Leslie, let
yeah.
me. Yeah, so I noticed that you do have solutions that you believe work for this. That if there was funding for it, it would work.
Absolutely.
Can you tell us more about that one? I think this group would love to hear that.
Absolutely. So what my mother did back in Ohio, and this, you know, goes all the way back to my childhood, because it was effective. We have good data. We showed that it was effective. What she did was she and the local public health department, her hospital system at the time, which was St. Vincent, and the local TV station, which was Channel 13, TVG 13, I'll never forget, put together a funding opportunity. Everybody contributed a certain amount of money, and they purchased a mobile unit. It was just a, you know, old RV, like you would, you know, take your family on a vacation in a mobile unit. They adapted it with, and there, you know, there was a bathroom, a kitchen, you know, it's a little mobile home. And what she did was, on that unit, they put little testing machines that people were able to, you poke your finger and you were able to get enough of a blood sample that they could analyze whether you had sickle cell. If you had, you know, and I don't know if you're aware, everybody may not be aware of sickle cell, but you can have either the homozygous gene, which means you're going to actually have sickle cell. You could have 2 of the 4 alleles, which would mean that you would have the trait, which, you know, could be completely asymptomatic. And then you could have like 1 of the 4 alleles, which, you know, you're just, you don't have any symptoms at all. And then based on that information and the similar information about your potential partner, you could get information about whether or not your child would be born with sickle cell or with the trait. And so what her goal was to take this mobile unit out into the communities of the entire Southwest Michigan and Northwest Ohio region and test every person at risk for sickle cell to see where they fell, if they had it or the trait. And once that was all completed, you know, and in the process, she would also refer. So when a person came back positive, either for the trait or for the actual disease, they would then be referred to hematology oncology, where they would get the support and treatment that they needed. Or they would be referred, if they requested, to genetic counseling for more information about the possibility of having children with or without the disease or the trait. So that was how it started. Once she treated and tested all of Northwest Ohio and Southwest Michigan for that, she extended it a little bit into middle northern Ohio, but primarily that whole area was treated, was tested and referred. And so once that was done, she said, well, you know what? Let's not lose this opportunity. We went back and began to test everyone for cholesterol. That was the, you know, preventative heart disease. And so she had some testing machines on the unit. We went out, we asked people. And so we went to the Ford plant. We went to the General Mills plant. We went to some of the church parking lots. We, you know, went to like the fairgrounds and some of these places where a large number of people would congregate. And that was very effective in that we had every single event, we would have an exit sign-in sheet where people would say, you know, hey, did you value this service today? And it became more and more popular throughout the area. And every time more people would attend, and the rating, those exit ratings would go up. And it was very, very effective because we were doing blood pressures, cholesterols, and glucose. And so we picked up a lot of people in the community who are previously undiagnosed diabetics, and we got them into care and on their insulin. We got a lot of hypertensives on their blood pressure medicine and reduced the risk for stroke, heart attack, etc. And we got a lot of people counseled for their cholesterol, and we picked up several people at very high risk based on those cholesterol levels. And so the other part that became very helpful was after we added that particular service to the mobile unit, after that, we went back and tested prostate. We hired a Black female urologist who was able to do prostate exams in the unit on site, which again reduced the risk for prostate cancer, as we know in African-American males at higher risk. So the mobile unit became the source and the center of preventive care in the communities at risk in that area. And it was a brilliant strategy. It worked. It was, you know, we picked up a lot of people and we kept them out of the ER. And that was the other benchmark. So there were several benchmarks. We wanted to see a reduction in stroke and heart attack in the community, which we absolutely met. We wanted to see a reduction in the incidence of prostate cancer surgeries in the area, which we absolutely met. And we wanted to see a reduction in amputations and acute diabetic crises in the emergency rooms. And all of those were benchmarks that were met. But the more important part is the communities were better served. They were more appropriately served by clinicians of color. And at the same time, clinicians of color were recruited into medicine because they could see in the communities, Black clinicians in the communities doing this work and satisfying people and having very meaningful conversations and meaningful relationships with these people. And so that is a way that people are specifically benefiting from the mobile unit going into community. And that is a big part of what House Bill 2337 called for. But again, even though they acknowledged the problem, acknowledged that racism was an issue, declined to put one thin dime behind it. And again, that is a form of institutional and chronic trauma. And again, it's going to increase risk for what? Mental health issues and justification for protest. I am telling you, if you think about it, you know, the complaints about majority culture against the protest is that, you know, you should just behave. If you just did things right, if you just, you know, work within the system, violence is not necessary, etc. Well, what happens when you work within the system? This is a perfect example of working within the system. A year and a half of my time, free of charge, every evening, every Tuesday evening, for a year and a half, consulting with people on the data, bringing, you know, very well vetted data. You know, this is, you know, brand new, peer-reviewed data coming out of Harvard, Johns Hopkins, CDC, NIH. I mean, this is, you know, well-vetted stuff, and yet no traction. So I think it's really important when you see people protesting. And again, I think this is a great opportunity when you talk about how do we talk about this to patients? How do we bring up racism in these difficult conversations? Perfect example to bring that up. You know what? We've got people who are doing this work legitimately, trying to work within the system with credentials behind their names. 20 years of primary care practice should be enough to validate any kind of House bill with my signature on it, don't you think? Okay, and yet no. So I think when people talk about racism, this is another answer to the question about, you know, how do we bring this? How do we approach racism directly in the moment? I think this is the way we bring it up, to say that it's institutional and it's justified. The protests can be justified because when you try to work within the system and it doesn't work and people are still dying, okay, the question is, what would you do? And in fact, I talk about institutional issues. I have been very disappointed in the ecumenical community as an institution, because it just occurred to me when I was asking, what would you do if this was your life, your kids, your family, your culture? It makes me wonder too, what would Jesus do? And where has the ecumenical community been? And so when we go to these institutions, which people of color have traditionally supported, like the ecumenical community, and yet we're seeing very little traction, very little call out, very little, look, you know, if we were to get all denominations of religions together on this issue, which, let's face it, no matter what type of religion you practice, there is no deity that validates and supports racism. So when you go back to your houses of worship and you say, you know, hey, congregation, I got a question. You know, what are we doing about this? You know, this is another institution. And again, we're talking about institutional racism here. Interpersonal racism is nothing. We know this. As people of color, we deal with it every day. That person that cuts you off, that person that flips you off, that person that, you know, obviously drives offensively, because that's another issue we know behind the wheel. No matter what your gender is, it's not easily identified in a car. No matter what other ism you face, there is nothing so visible in a car as black skin. And these are the ways that the institutions abuse us. What are you going to do? A cop pulls you over, okay? We have all seen the issues around DWB. So I think it's really important that these things come up, and that when you discuss racism on a larger scale with your patients, and again, ask that permission, because it may not be a good day. It may not be a good day, and you don't want to re-trigger someone who is already carrying that burden. So Damon,
Leslie?
I hope I was able to answer that question. If you have any further questions about the mobile unit, it is I've got great stuff. It is amazing, the stuff that you can do with that unit. You can put voter registration information on there. You can get people to come and show up at the events where the mobile unit will show up. You can do it in a parking lot of a church, for instance, where people feel really comfortable. And you can say to them, hey, we're going to be here next Sunday. Don't eat any breakfast, because we're going to poke your finger, and we're going to take a look at your cholesterol, your blood pressure, your waist circumference, your glucose. We'll look at those risk factors. The one thing I wanted to put on my unit, I also had is a very small, it's called Easy One. It's a very small pulmonary function machine, because I think over the virus, over the last year and a half with the virus, a lot of smokers started smoking again. And so I've been very concerned about that. I would really like to put one of those on there too, because we can test for COPD, which is the lung disease associated with chronic smoking. And what's great about that little machine is it comes with a printer. You can print the results out, give it to the patient, and guess what also comes with the pulmonary function? Lung age, which I love it. I have a 63% quit rate among my patients because that lung age is so compelling. You know, you get a 42-year-old come in there and he's only smoked a pack and a half a day for like 4 or 5 years, comes back with a lung age of 56. Let me tell you something, those cigarettes are done. I mean, I love it. And it's not just for COPD. We know that we have a disproportionate amount of asthma in communities of color, and we can diagnose that as well. So I just think, you know, it's all about the heart and lungs, and we can do a lot of screening on this mobile unit. And also, one of the things I love about it is there's a small area that I would put on the unit for a library. And I have some wonderful anti-racist literature from pre-K all the way to, you know, Cornell West. So I think it's got a great deal of utility. The possibilities and the adaptations are limitless. We could put testing for the virus on there. You know, we could even have, with the pulmonary function device, you can do it pre and post bronchodilation so that you can see if bronchodilators will work for that. We have a lot of people who have reduced lung function after the virus, and we can help to diagnose and triage that. The cholesterol, glucose, blood pressure cuffs, you know, all of that. The other part of the protocol that with that mobile unit, though, I have to tell you, is that I'm actually doing screening and treating the health effects of racism, because we get biomedical markers like the blood pressure and pulse, et cetera, at baseline. And then we repeat them while patients are taking an implicit bias test. And in the middle of that triggering question, we repeat those biomedical markers and we show the effect of the heart on thinking about racism, internalizing it, and reflecting on the possibility of being racist. And so we are able to track the stress response of racism in that moment. Because quite frankly, what we're seeing on even with the calling out of it from CDC, people are still talking about social determinants and using other words, healthcare accessibility, etc. They're still not using the word racism per se and studying racism like we would the virus. That is what we should be studying. Yes, we all know the effect it has on community. Yes, we all know the waste of Black lives and, inappropriate incarceration and police violence. We all know about that. But we need to talk about racism itself and be studying racism, the phenomenon, the pathology of racism, like we are the virus. And that is one thing we are not doing. We are not doing that. We're looking at the biosocial construct around it. We're looking at the sociocultural effects of it, but we are not actually getting to why are people racist? How do we inoculate against racism? What is the pathology and the path of it? We know how viruses act in the body, right? We know how they work. We need to be looking at how racism works in the body and in our culture so that we begin to inoculate against it. And that's the other thing we do on the mobile unit, is to inoculate against hate, because we do not exclude anyone from our screenings. When we go out into community, we may be looking at those places that are predominantly places frequented by people of color, but we do not exclude anyone. So we have white people coming into the community. We have, into the protocol. We have Asian Americans. We have Latino. We don't exclude anyone. And I think that's the other piece that is so critically important, because it is a community-based intervention. And when people are in their own community and feel comfortable, they will interrelate with each other. And having cops come as well and say, hey, cops can skip breakfast, come out and get their finger poked too. We're not, and it's another way that we can get the police to interact on a human level with the community. And I think that's another real benefit that we were able to see in the previous paradigm. It worked great. Cops were there, they were able to talk to people as people, and there wasn't all this, HIPAA. Nobody wants to see what privacy issues, oh, be careful. No, people would walk around with their results and go, hey, look what I got a this, I got a that. Ooh, look, you got a this and that. Hey man, your triglycerides were up. How about we talk diet with you? My HDL was low. How about you and I work on a diet and an exercise program together? And people did that. It was a human interaction, and people were very, very, it was a welcoming environment, and people welcomed us back as well. And we would come out, and the point would be 3-6 months later, we'd come back and see if the things we recommended had made a difference. And you know what? Almost universally, they had. And at the very least, people came back. And that's the point. That's the establishment of relationship. And it was really, really, it was awesome. And so thank you so much, Lee, for putting that information in about writing to your legislators. I have spoken with some of our legislators. In fact, I went to Washington several years ago with the Chronic Pain Patients Coalition. We were advocating for chronic pain, better treatment of chronic pain in patients and I was with the Sickle Cell Coalition at the time. And I spoke with these guys and their staff. And I got to tell you, real nice people. Don't want to, please do not misunderstand me. But it just felt very superficial. It felt like, oh, thanks for coming out. We just really appreciate you hearing your perspectives, and here's my card. And it was, sort of nothing to say, wow, I really understand that. How can I act on this? It was not that. So, and again, it frustrates me that we're putting public health matters into the hands of politicians. We have seen with the virus, people die. It needs to stay in the clinical space. And that's why the declaration by CDC is so critically important, but it's not enough. I need these people back to me about action steps. And that's been a real issue. So that's the other thing that just happened this week. And I'm kind of excited about it. Just heard from Walensky's assistant about, how do we proceed? Because I sent the message directly to Walensky and said, hey, people, it's 6 years old. Y'all late to the game. Come on now, what you gonna do? And so she sent me a message back saying, we'd like to know to whom to refer to, who would you like to talk to about this? What special department can we route you to? And I'm going to send a message back going, the special department was where I what Frieden did in 2015 when I wrote him was he didn't even respond to me. He sent my letter over to the Office of Minority Health and Health Equity, where Leandris Liebert, who is in charge of it, declined to do so. So we're not going back to OMHHE. We wanted to stay directly on the director's office, and I want to directly, communicate with her. I'm not going back to OMHHE. So I think
Leslie, I want to call out a strategy that you just used. So the medical community tends to use euphemisms like social determinants of health. You called out, as many Black practitioners have for decades, racism is a pathology.
That's right.
It's a pathology. It needs to be inoculated, which then says, okay, it's like a pandemic. It's like a virus. You need to, get into the DNA of it and explore it. And that's a thing that practitioners can use to talk about it directly. Can you comment about that more?
Absolutely. And a couple of other things that directly relate to the virus. So one of the things we know is the virus has different expression, and it has we're seeing different compliance rates in terms of vaccination around the country, right? One of the places that you see some of the most racist practices also tend to be very low vaxxers, right? Because we don't have a trust in the system. Because the system's marginalized us white people now around all this talking about racism. And so we don't trust the system now. We used to trust the system when it was predominantly white and we were seen and heard and validated as white people. But now that we start talking about this racism stuff, I'm not trusting the community. I don't trust the system anymore. So these are some of the ways that we see not only anti-vaxxers, but non-believers with regard to racism. And so again, when we look at the last administration and the kind of poo-pooing that was done around, it's not that bad and you don't need a vaccine, you can take hydroxychloroquine or, and now we've got a lot of people who are feeling the same way about it and advocating for things like ivermectin instead of taking the vaccine. And so one of the things we know about communities of color is this higher level of mistrust of the system leads to these sort of non-traditional methods of healthcare, et cetera. And I think another way that we can begin to kind of bring these non-believers, if you will, back into the fold is to go ahead and validate that. Go ahead and validate it. Say, you know what? I understand why you don't trust the system. The system was not trustworthy with regard to Black bodies for many years. And in fact, I was going to pull up my PowerPoint presentation, but I'm almost like, forget it at this point. But I have a poster from the old American Red Cross. Remember how they used to say, swimming was all about Red Cross, was all about swimming. So I have this old poster from the American Red Cross, and it says, be cool around the pool, or whatever, and it showed all the things that you shouldn't be doing around the pool. Don't jump on people's back, don't run but walk, don't dive in the shallow end, and every single one of those prohibited actions was being undertaken by a person of color. And all the white kids in the pool were doing what they should be doing, and every single prohibited behavior was being engaged by Black kids. And it was like, and that was one of the reasons I like to pull that up so people can understand that, again, this systemic and institutional sort of racism is very subtle. It is not it's not all Black people are bad, simple thing. And I think, so I really, really love that. And I can make that available if you'd like. But I think the issue for me is when we see these subtle, pervasive messages, we certainly can understand why our communities of color are mistrustful of the institutions. I think the issue is to say, are you going to let your mistrust cost you your life? Or are you going to, listen to me, a clinician of color, who is advocating for at least this much of a participation in the institution? Now, you can get your vaccine and still go home and not be that doesn't mean you're, marching lockstep with the institutions that have abused you. But you can come and modify your risk by data-driven analysis about what will and will not work. And I think that's the way to really approach it, and to say, look, this is the testing they did on communities of color before they launched the vaccine. Because I think that's the other part of the narrative. It's like, well, yeah, they test all this stuff on white males. I'm not going to do it. And it's like, well, yeah, that's true. But here are the data about efficacy and safety in communities of color, because they did do that research. So I think those are some of the ways that you can kind of overcome that narrative, despite the fact that there are going to be people, no matter what you say or do, who are going to say, you know what, I'm not down. And in that case, what you can do is mitigate risk and just start talking to them about, okay, then I need you washing hands. I need you covering up. I need you, for those other individuals in your life, not necessarily yourself, to reduce their risk of exposure as well. So those are the kinds of things you can do, because there will be times when there's nothing you can say or do. I'm not going to do this. Okay, then here's what you can do. Because you have to meet a patient where they are, right? Yeah. So I just, super, super important. So the mobile pulmonary machine was called Easy One. It's got a little dock. It's got a machine. You can get a machine printer that will hook up to it, and you can print out those results. So it's Easy One. Yeah. Yes, Damon Hawkins, we are all affected by it. Absolutely. Super, super. Thank you so much for making the recording available. And let me see. Were there any other questions? I'm looking to see, are ecumenical organizations a form of the power that wants to continue current policies regarding, I got to tell you, I practice medicine in a very empirical field. I have tried very hard to knock at the door of whatever deity is out there, and having gotten no response and the door staying closed, I'm kind of on the, I don't know so much. I'm an empirical person. So in terms of the ecumenical organizations, they are a sort of power. I do not know their motivations. I do not assume anything about that. I would love to have ecumenical organizations reaching out to me to help to promote the mobile units, because they got a lot of money, and because they are a source of power where typically communities of color would congregate, and I would love to have them back what I'm trying to do in terms of heart disease and mental health. But I don't understand why they don't take a more active role. I have no idea. I mean, when you think about Dr. King and the fact that it was primarily the church community that backed his work and helped him organize and made huge changes in the way racism is addressed in this country, I have no idea why they are so quiet now. I should think that they would be the first ones hollering and screaming and backing John Lewis. And the only person I know that I really respect in terms of that is James Lawson. And I have done his nonviolent training, and I love him. I love. And I recommend everyone to reach out to him, send him all the love you can, because he is getting older. He's the oldest and final remaining member of that, the group of Dr. King's cohort. So, I would, reach out to him, send him love. Reverend James Lawson. He's brilliant. He's wonderful. I love his training. I've done his trainings. He's a brilliant person. So, but yeah, I think the ecumenical community has been very quiet on this, and I'm very disappointed. Let's see. I feel like there's new questions. So I am not currently doing the mobile units because we do not have any funding. Like I said, that was a part of House Bill 2337, and they completely defeated it and said, oh yeah, we're going to go ahead and call this a problem, but we're not going to do anything to fix it. So yeah, that was very disappointing. Self-care, critically important. I do as much as I can. For me, it's about swimming. I swim as much as I can. I have a little machine in my backyard that I swim in, and it's my happy place. I listen to music in my ear while I swim. But again, that is another thing that many communities of color have been marginalized around. A part of my PowerPoint presentation that I also have is a picture of a couple of little black kids swimming in a pool, and a white man walking behind them pouring acid into the water. That is an old picture, but it's one of the reasons that a lot of communities of color just don't swim. As soon as we had public pools, and this is the historical nature of institutional racism. initially into communities, they had a lot of swimming pools because they found that that was a great way for kids to stay healthy, to learn to swim as a drowning prevention. But as soon as the communities began to, inner city communities started going out into the suburbs and actually doing better during the civil rights era, right after the civil rights era, they started shutting down those pools. And again, that's institutional racism. So a lot of people wonder why Black people don't swim. It is not, it has nothing to do about the physiognomy of the Black body. Yes, there may be a higher muscle bone ratio, and the having the genome originate closer to the equator. Yes, there is some bone density ratio difference, but that does not preclude swimming in the least. As a matter of fact, it actually argues that swimming should be taught to these communities at an earlier age and more frequently than in white communities because of that very fact, the density issue. But it is not no, I've been a water safety instructor for 40 years. I will tell you that it is not impossible for Black people to learn how to swim. Matter of fact, I teach it and promote swimming in Black communities as a risk reduction for drowning. As we know, in some communities, Black children drown at about 3 times the rate of white children. So that is another part of a campaign that I tried to pitch to international swimming, and they chose to go with Colin. What was his name? Colin, the Black guy that
Kaepernick.
No. The Black swimmer that won with Michael Phelps that year. Colin something. But anyway, he's working with international or USA Swimming now. But I think that it could have been linked very closely to the unit, very closely to the larger picture of dealing with racism in athleticism and in sports in general. And I think that would have been a really great campaign. But again, hard to be heard living out here in the whitest city in the nation. So it's been very difficult to push this stuff forward. Thank you for bringing up William Barber, Terrence. I actually spoke to him briefly. And again, one of the problems we have in this country is we are so immature. By comparison to China, Japan, some of these other ancient cultures, we are so immature. And this idea that you can only do one thing at a time is something that is just so bizarre. People are constantly telling me, you should really narrow your focus, and you get better traction if you narrow your focus. Well, it's about heart disease and prevention. Hey, it's about racism taking people out. It's about prevention. And I have contacted him, and it's all about this Poor People's Campaign. The understanding that the way it is that you cannot understand that classism and racism go hand in hand. Are you kidding me? Is that really so hard for you to figure that out? You know what I mean? And so we have a lot of these institutions that are taking a stance or making a statement or have a political position against. But, positions without traction, without action, without funding, without specific interventions, it's like the CDC. It's doing nothing. So it's like, yeah, okay, you're right. Racism is a thing. Hit me up next year. What? So I think that's the important piece. I would push back on every single time you hear any institution or group or whatever come out with an anti-racist statement, push them my way and say, you know what, you're not doing anything about it. And so until you do, save it. It's a hollow victory. It's a lame, proclamation. It costs you nothing to sit in the corner and say, oh, gee, ain't that awful? That's the problem. So I think, and yes, the Presbyterian Church has taken a stand. People are making this, everybody's coming out with this statement, and my point is, great. People of color are still dying. Until that changes, your statement is hollow. What are you going to do about it? So we have a MoveOn.org petition that started way back in 2015. It has like 17,000 signatures to force CDC to admit that racism is a public health crisis. After all that time, 17 grand. Are you kidding me? Okay, so now that they've done it, the petition is sitting, doing nothing. And I'm like, okay, go into the petition, sign it, share it, put something in there about, hey, here's somebody who's been trying to get you people to do this for 6 years. What are you going to do about it? Thank you very much. Write Rochelle Walensky. Tell her, you know what? This person wrote you 6 years ago. Now that you're doing it, what are you going to do about it? You need to reach out to her about the interventions. They're vetted, they're data driven, they're bottom up and top down. They've got multifaceted. They incorporate all people. They do not exclude. And they address the actual virus, not just the fever. And I think that's the issue. Racism, if it's a virus, then all we're doing is putting Tylenol on board. We haven't gotten even close. And if it were a virus like the COVID-19 that affected white bodies, please believe it'd be all hands on deck, stop, drop, and roll. Get me some money. I want a vaccine. I want to, and my point is the same. When are we going to begin to value and validate Black bodies the way we do others? So, questions? I've had my tirade. Good.
But it's data driven.
It's data, absolutely.
And practical.
Yeah, if it's not data driven, then it's going to get pushback. And for people of color, even with data, we get pushback. My point is, until we start to actually dig in and do the dirty work, and yes, it's going to be dirty. It's going to be messy. People are going to get their feelings hurt. We're going to have a little tension. It's going to be a little ugly. But again, these are all lessons we can learn from the virus. There are a lot of lessons we can learn from the virus. The next time you hear someone say something about COVID-19, reframe it thinking about racism, and then think about what that would look like to you. What does it mean to you? And that's what I'm asking people to do if they sign the petition. To go in, what does it mean to you? What have you ever seen a Black person stop by a cop when you know it was a freaking light on their license plate? Are you kidding me? I mean, have you ever thought about intervening when you see racial injustice? What have you done? What have you thought? Think about it when you see something like that, whether it's the virus, whether it's, mental health issues, whatever type of public health issue that you see in the world, reframe it in terms of racism and see how you feel. What would you do? How do you think your government should support you, should validate you, should walk its talk? And I think those are the kinds of things we each need to be asking ourselves. And wherever you worship, wherever you work, wherever you buy your groceries, wherever whatever park you frequent, etc. This is how you become an anti-racist. Raise your awareness. Think about it, what it would look like to walk around in brown skin, doing exactly what you do. Think about how you would feel if it were you. And think about your neighbor. If your neighbor were Black, if your boss was Black, if your church mate, your sorority, fraternity mate, the lady that checks out your groceries, raise your awareness. So I just think it's super, super important. If you got, if you feel uncomfortable thinking about race, think about how it feels to walk around in that skin. Super, super important. Any final questions, thoughts, feedback, concerns? Besides wanting to get up and move off your butt? Which is good. At the end of this, I hope everyone will get up, stretch, raise your arms up over your head, bend back over your back, twist and bend, lift your knees, stretch. There you go. Go, Elaine, go. Yeah, everybody get up and move. Super important. Good time to get some cardio in. Stretch first, drink lots of water, and get some cardio.
Leslie?
Yeah, Lee.
What is do you have a link or anything to the CDC petition?
Oh yeah, it's moveon.org. All you got to do is go to the moveon.org site and put in my name or racism in public health or, whatever, and it'll pull up. I suppose I could pull it up. It's just like I said, it's just the moveon.org petition. My computer just seems to be so freaking slow these days, but yeah, so here it is. Let me put it in right here. Yeah, so that's the, and it's old. Oopsie. Sorry, I didn't mean to put it in there too, just Fatima. Everyone, there you go. Yeah, anybody else sick of Zoom besides me? Totally. So anyway, there's the petition. Feel free to follow me on Facebook. I'm on Twitter. Don't do much on Instagram, but mainly Facebook, just because I got a lot of patients that hit me up. But yeah, feel free to follow me, any of that kind of stuff. Elaine, did you have a question?
Yeah, somebody else did in the chat earlier, and I just wanted to catch it. And it was something about how do you take care of yourself in the throes of all this?
Oh yeah, like I said, I swim.
Okay. Okay.
I swim. I do martial arts. I like Krav Maga. I like Taekwondo. Meditation, something called Silva mind control that I took back in college. You know, but it's mainly about exercise. I have a new diagnosis, which is why I'm late today. I was trying to get some care around it. And so that's been a challenge. But, you know, that's the same kind of stuff. I take my meds, I get some sleep. I try to, you know, eat healthy, high fiber, low glucose, low, you know, anti-inflammatory diet. I like Andrew Weil's anti-inflammatory diet. You know, that kind of stuff. It's about heart disease. You reduce your risk for heart disease. You reduce your risk for just about everything. Mental health, hug your people, reach out, get people who give a crap about you and hold them close. Love on your people. Yeah. Hey, Susan, how you doing, honey? Any other questions?
No, I'm good. Thank you so much for all that you've told us and how you said it.
I got a lot of blah, blah, blah. Sorry about that, but hit me up on Facebook. I'm happy to, you know, answer any questions or continue to communicate with everybody on Facebook if you like.
Hey, out of curiosity, just for the funding for the mobile unit, like I know you've been pitching it as well. Do you have that somewhere where, you know, if a community wanted to do some of the funding for that for their community?
Yeah, check out House Bill 2337. It's right in there. I think our budget was something like $4 million for 2 years. But honestly, I got to tell you, I feel like we could do it for a lot less, especially if, you know, we've got a lot of those mobile units right now are way on back order. But the cost of used vehicles is just like getting to be this huge thing. I know there are used mobile units out there that could be retrofitted. You know, people who want to donate those as people age out and can no longer go out and, you know, take their mobile units out into the communities and stuff. You know, a donated mobile unit would probably start off because I've already got the testing equipment here, and I could get donated a whole lot of stuff if, you know, if we started out with the unit. I think that's a really good question, a good point. Even if it wasn't a whole mobile unit, if we were able to get just like an SUV or something like that, where we could start slow and small and do a couple of testing events, and you know what I mean? I'm not, you know, it's not an all or nothing issue. And I have actually taken my testing equipment, and I've done a few events where I've just taken my blood pressure cuff. And, you know, we've seen a lot of people in the community with really gnarly blood pressure. So, I mean, there's a lot of little interval steps that we could do without doing the major big thing. But I think, you know, getting a mobile unit and getting into some of these outlying communities where people are absolutely clueless. I've had so many patients who come in and say, you know, as soon as I got outside of Portland, it was like Kentucky. You know, it was like whatever that movie was with like the backwoods where people were doing, you know, I was like, oh God, it was right on the tip of my tongue. But I think, you know, it's just really backwoods as soon as you get out of the city of Portland. And by being able to go out into those communities and do some anti-racist training and screenings and heart disease risk reduction and things like that, get people used to seeing clinicians of color and getting patients of color used to being touched, have the blood pressure cuff on your arm without being escalated and freaked out. You know, these are ways that we can get communities of color to eventually present for care, but expecting them to do that now is just, you know, it's in some instances, it's just unrealistic. Yeah.
Yeah, and it makes a lot of sense to go out into the community. Here in Eugene, Springfield, we've kind of learned that's what we do with the vaccines, and I know that's what others are doing too. Absolutely. Like the NAACP is having vaccine clinics at their office. Yeah, so you know, very small, localized.
Yeah, and that makes a really, you know, another really good point that I was going to raise. you know, if they had listened to me back in 2015, we would have these mobile units all over the country. I'm going to tell you something. We could not only have saved hundreds of thousands of lives to the virus by having those clinics, because we could have gone out into communities on those units. We could have gotten the testing in a third of the time. Every single person would have been tested by now, you know, earlier, and we could have put the vaccines on the units. The units would already have had established relationships with these communities, and it would not even have been, it would have been a no-brainer. Hey, we're coming out to the church this Sunday. We're going to be testing. Hey, I want everybody tested. Anybody with symptoms, you're going to be at the other side of the parking lot. This is what we're going to do. I mean, we could have had this, this would have been tied up. We could have beat China. Had we listened to me back in 15 and had those mobile units, people would not have been coming to clinics to get care. We would have gotten them out into the community for early screening, early preventive measures. We would have had all kinds of health, primary health data out there for people to participate in. And incidentally, those pre-existing conditions that put people of color at higher risk would have been better managed, because most of them were types of heart disease and COPD. We would have had those better controlled. Our communities would have lost a third of the people that they lost. We would have had all of this stuff dialed in before it even became an issue. And then once the virus came, we'd have had the screening early. We'd have had the information out early. We could have brought gallons and gallons of hand washing stuff with us on the mobile units. We could have had those kids tested, and the vaccines could have been, we could have met our vaccine benchmarks, you know, months and months ago. We all could be back to work by now. And the other thing is, quite frankly, if in 2015 we'd have had our mobile units, we'd have had voter registration on them, and we would have had a completely different outcome to the previous presidential election, which would have dropped everybody's mortality and morbidity, quite frankly. So I think these are other things that people really need to get a clue about. It's about unity, community, and education.
So, yeah, I know you said you wanted to do that for the to kind of let Oregon be that the example for nationally how to do it. So I guess I was wondering if the state itself is not pushing for it, is there like other organizations can get involved to kind of push it basically out in.
Yeah, well, Oregon Public Health Association was a part of the cohort that we were all on board. Everybody, Virginia Garcia, Oregon Public Health Association, our local NAACP had a medical committee on which I served. They were down. I mean, I'm more than happy to work with anyone on getting that funded and getting it launched. I'm happy to work with anybody. But I also have some people back in Ohio, because what I wanted to do was a pilot program out here and a mirror program back there, because that's a very diverse community. So we would be able to show how a homogenous area like Portland could benefit, but also to show how a very integrated community like that in Ohio could also benefit. So I was trying to set up both protocols so people could see its very universal utility, but it's been very hard to do that. Okay. But yeah, our local public health organizations have been, you know, loud in endorsing and soft in backing. And again, you know, it's all about the blah, blah, blah and very little traction, which is, you know, again, a health risk in and of itself.
Yes.
Yeah, so hit me up. You can, you know, like I said, I'm very fine. I'm easy to find. I'm on Facebook and whatever, you know, feel free to hit me up. And yeah, just let me know when you hit me up that you've been at this training seminar, so I can have some kind of context to how I can identify you. But, you know, I'm very happy to hook up with anybody. I'll work with anybody. Ask anybody. Very happy to talk to everyone. You guys have a great afternoon, and be well.
Thank you very much, Leslie.
Thank you very much.
Thank you.
Paul, take care.